Hello and welcome to the first session for the key messages for Friday. My name is Monica Cruz Lemini and I will be the first presenting, and I would like to thank you all for being here in the name of all my co-hosts Elisenda Shark and Francesca Bardi. We will present in Hub 1 the end of day summary from Next Generation Isuog. So to begin, the first workshop in the morning was the broken heart detection and correction. The chairs were Julian Carvalho and Fatima Crispi, and we have various interesting presentations. Ravi Chawi presented what not to miss in the first trimester fetal heart. And he basically gave these messages to keep it simple and examine systematically the heart in first trimester without missing situs, 4-chamber view, 3-vessel and trachea view, and using color Doppler. He also recommended to master your ultrasound equipment. Simha Yagel.
Monica, we don't see the slides.
You're not seeing the slides?
No. If you want. Sorry. Eh?
I'm sharing the screen. I'm really sorry. Yeah. Okay, so now let me know if you see the slides now.
Yeah. Now, yes, perfect.
Okay, so I don't know why this is here, but we will do this like this.
We see well, very well.
Yes? Okay. So Simha Yagel presented on B mode, M mode, 3 and 4D, and combining modalities for comprehensive evaluation. We had an overview of different modalities for the fetal heart evaluation, B mode, M mode, 3, 4D, fetal HQ and MRI, and he also recommended for assessing left heart function, MPI, and for right heart function, TAPSE. A very nice presentation was that by Monique Haag for genetic testing for fetuses with heart defects, what, why, and when. And here the take-home messages would be that around 7% of congenital heart disease will have a normal chromosomal arrays, and around 6% will have an abnormal exome. So in general, around 16% euploid fetuses will have pathogenic genetic variants. And this was a very nice presentation. I would recommend you very much seeing it. Gregory DeVore presented on mapping fetal cardiac function with speckle tracking, and he presented an extensive overview of speckle tracking analysis for the evaluation of fetal cardiac function and the fetal HQ software. And examples of clinical applications were shown. And finally, Dr. Julian Carvalho did a scan demonstration of the approach of evaluating the fetus with arrhythmia, showing examples of pulse Doppler for pulmonary vessels, the left ventricle outflow tract, the aorta inferior vena cava, and the evaluation by M mode for the atrial and ventricular contractions. The next session, which were the oral communication, the hot abstracts in cardiac imaging. The chairs were Ravi Chawi, Monique Haag, and Harsha Shah. And these were very nice abstracts, which presented with the following. Dr. Contro showed that a restrictive or narrow foramen ovale are associated with worse neonatal outcome in complete transposition of the great arteries. Dr. Chiapa showed a study of 96 right aortic arches, and he described 7 different types of ductus arteriosus and their different associations with congenital heart disease. And this was one of the very most beautiful presentations of the session with very nice images. Dr. Ohm showed a study assessing prenatal brain volumes in congenital heart disease with fetal MRI and confirmed diminished growth like other groups. Dr. Reina Komatsu from Japan showed an artificial intelligent guided auto-detecting model for identifying pulmonary veins in an apical 4-chamber view. They did a training set and a test set, and they found a positive predictive value of 93.6%, which means that we can have artificial intelligence identifying normal pulmonary veins and aiding us in the scanning of the fetal heart. And this was also one of the highlights of this session. We also had very interesting topics about Dr. Vedel and the association of VSD with chromosomal aberrations, where in their cohort they did not find an increased risk. Dr. Witschek also used the single artery of the 3-vessel and trachea view as an important feature for different types of congenital heart disease in first trimester, not just for the transposition of great arteries. Dr. Radha Krishnan from India spoke also about the 3-vessel tracheotomy in the first trimester and about the signs of the X and the V signs for the crossover of the great arteries and diagnosis of congenital heart disease. Dr. Buana spoke about the 3-vessel tracheotomy in first trimester for right aortic arch. And finally, Dr. Butet from Barcelona described different types of cardiac remodeling in IVA fetuses and showed that there are milder changes when you use frozen embryos when compared to fresh embryos. So this was a very interesting session on cardiac imaging. Then we had the masterclass for the whole heart, a quick guide to assessing structure and function. This was chaired by Julian Carvalho with Joshua Koppel, showing the 4-chamber view, speaking about the 4-chamber view and saying that it's not simply counting to 4 chambers, it should be completely evaluated. Is something too big? Is it in the wrong place? Is there something that doesn't belong? Is the axis okay? And if you think that something's not right, you should investigate. But it is also very preferable that if you have a patient that has risk factors, you do not stay with screening, you go directly to a fetal echocardiography or echocardiogram. And Dr. Abu Hamed spoke about the outflow tract, and he spoke specifically about 3 critical anatomic features. One, that the angle of the IVS and aorta should be analyzed to see the way the left ventricle outflow tract goes. 2, to evaluate the blood flow that goes from the right ventricle to the ascending aorta to diagnose defects at this level and possibly tetralogy of Fallot. And 3, about the left ventricle outflow tract, that it does not split in the transverse plane, thus showing a pulmonary artery instead of an aorta. He also specified that the 3-vessel trachea view must be clear, and he presented very nice cases for tetralogy of Fallot and transposition of the great arteries and how to evaluate them. So the heart sessions were very, very interesting, but now we're going with Elisende Shark for the fetal surgery sessions.
Thank you, Monica. Great summary. Well done. So for a fetal surgery, we started with a very nice workshop that was chaired by Anthony Johnson and Rogelio Cruz Martinez. And we started with a nice presentation of Dr. Sanz Cortez, in which she talked about the results of the 3-layer technique that they are doing in Houston. They have a very good obstetric results with a gestational age at delivery 38 weeks and a PPROM below 30%, with a good neurosurgical results with a hindbrain herniation reversal next to 100% and no leakage at birth. And she pointed out some very nice results, now results of about things that can give worse prognosis. For example, the occurrence of choriamnionic separation in fetoscopic surgery that increases by 20 the risk of PPROM and increases by 10 the preterm delivery rate. It was followed by Jan Deprez that talked about congenital diaphragmatic hernia. The present is that the right congenital diaphragmatic hernia and has better result if you do fetal tracheal occlusion, and we are still waiting for the results in the left congenital diaphragmatic hernia. And the future is like the application of the balloon real set that is easy and risk-free. You will see more data later, and also to the application of sildenafil in these patients. The third presentation was about twin-to-twin transfusion syndrome. Julian Stimmerman present data about the randomized trial about expectant versus laser therapy in these patients. The good thing is that there are no differences in the primary outcome that was neurological or death in these fetuses, but they observe an increase in the PPROM of course in the laser group, 10% versus 30%, and they observed that in those cases that was not progression from the stage 1, the result was very good with a 90% of cases with the 2 survivors at birth. The fourth presentation was done by Luc Juillet. He talked about the use of the LAM model for spina bifida in different aspects. So he first demonstrated that it was a very good model for studying spina bifida aperta. And he tested different things and demonstrated that the best of the more neuroprotective technique was the multi-layer repair, that if you use humidified and heated CO2, this is safe for the fetus, and that with the 2 or 3 pore technique, you can rate the 100% rate of water tightness. That is the best for the brain. And that they also introduced the 5-step training that also Jan de Press talked later, so I will explain later on. So the final presentation was done by Dr. Gratacos. He talked about selective IUGR and the different therapies that you can apply, laser versus cord occlusion. You here can see the results. So laser has an increased rate of preterm delivery, less survival of the fetus with appropriate growth, and also a subtle increase in the brain injury. But is a therapy that you can do it if you want, but you have to know that these are very difficult technique because it's not exactly or as easy as can be laser surgery in twin-to-twin transfusion syndrome. After this workshop, we have started with oral communications. So we have two nice communications about the future or the new development of new treatments or new materials. So we have to start with the application of a sealing system that Charita Micheletti explained to us that is feasible to be used in fetoscopic approach, and that has a short-term adhesion in the animal model in most of 60% of cases. Also, this presentation was followed by David Basurto that show us very nicely how they have developed this smart tracheal occlusion balloon that is deflated using MRI. And this is very good because avoid the second fetoscopy and this reduces the complications. But the good thing is that not only deflate, that this balloon is doing what is expected to do, that is increase the lung growth during pregnancy. Then these presentations were followed by one by Romain Corren. He explained about the how prenatal counseling in neural tooth defect can be improved, and the importance of the effect of the size of the defect and the evaluation of the motor function for better counseling these patients. So it was very, very nice presentations. And there were followed by one from Francesca Russo from Belgium. She showed us the results of the tracheal occlusion in isolated right congenital diaphragmatic hernia. And the first thing that show us is that the better survival predictor is lung size in this group of fetuses with the cutoff at 50%. And also the good data is that feto improves survival in these fetuses going from 50% to 41% in those with lung to height ratio below 50%. Also, Romain Corone show us data about the use of fetal aortic valve stenosis treatment. He showed data about more of 40 fetuses. They have got successful treatment in 70% of fetuses, and of those that get a term, that was more or less half of all the fetuses included, 54% have biventricular circulation, and this was related. It's very interesting because it was related with the success of the technique. So those fetuses with successful technique has a 70% rate of biventricular circulation. We have 3 presentations about twin pregnancies. The first one was done by Dr. Nakata from Japan, and talk about the rate of cerebral palsy in twins that was mainly explained in monochorionic twins by the complications of these pregnancies, including TTTS, selective IUGR, or placental abruption. Also, the group from Israel showed data about the presence of brain lesions in twin-to-twin transfusion syndrome fetuses, and that were around 10% in the evaluation during during the fetal period, and 30% in the evaluation after birth. And that associated factors were gestational age at laser and gestational age at delivery, also the occurrence of TAPS and weight discordance. And finally, a very nice, also an interesting presentation about the factors associated with placental sharing. That is one of the conditions that leads to monochorionic complications that can be predicted as soon as at 12 weeks. So measuring CRL or the discordance between the umbilical vein loop, for example. And finally, the last presentation was by Lina van der Beeken from Belgium also, and show very nice data on rabbit model that the fetal medication that we use for fetal surgery is safe for brain development, and is very interesting data for taking into account when we're doing this type of procedures. And the last session about fetal surgery was this masterclass, these hot topics in fetal surgery. Jean Deprez started and explaining us how to move on your own program if you want to do surgery for spina bifida. So he explained their experience in Leuven, and he explained that they started with experimental phase to choose the best technique in the lambs. Then he explained also that they have explored the learning curve of this technique, and they really know that you need to do 35 fetuses in open technique and more than 50 if you want to do minimally invasive technique. So you have to do this experience in order to reach the appropriate performance. They have a mixed training program using ex vivo rabbit, lamb, and also visiting centers in which they have the surgery ongoing. And he also presented some new data about the safety of the heated and humidified CO2 if you do a surgery of 180 minutes, and the relevance of water tightness for the hindbrain aeronation and motor function and results. And he really highlight the importance that if you want to do fetal surgery in spina bifida, you have to offer that under very strict conditions. And the last presentation about fetal surgery was done by Asma Khalil. She was talking about the complications in monochorionic twins. One of the most important messages that you should do ultrasound every 2 weeks in all monochorionic pregnancies in order to diagnose these complications. In the case of TTTS, so we know that the treatment is laser. And that should be offered at least when it's above the stage 2, and that we have to do weekly ultrasound after the surgery and deliver at 34 weeks. For TAPS, she talked about the diagnosis and that you should individualize the management of this condition. Also about the selective IUGR, that she proposed to use the Gratakos classification, and if you have a type 2 or 3, that was a normal umbilical artery, consider the treatment. And also about the discordant malformations, that you have to decide if you want to do expectant versus selective termination depending on the malformation. And finally, about the selector of the intrauterine fetal demise in one of the twins, just summarizing that the risk of death of the other twin is about 50% and the risk of brain lesions about 25%. And that's all about fetal surgery. So now I think that we are going to move to the first trimester. It's going to start be done by Francesca.
Yes, I'm going to take over. Thank you both. Thank you, Elisenda and Monica, for your nice summaries. I'm going to start about the first trimester sessions in the auditorium 2. So I'm going to start with a nice workshop that we saw this afternoon. The first presentation from Dr. Pertile was about low fetal fraction and sex discordance. So we define as low fetal fraction below 4%. And we've seen that it's in about 1.2% of the pregnancies with which will undergo an IPT, and we will get a no-call in around 0.5%. In these pregnancies, the risk of trisomy 21, 18, and 13, as well as triploidy, is higher. So the question was, how do we approach these cases? And well, first we should review maternal history and maternal characteristics. So also check for BMI, which is known to be associated with a lower fetal fraction, and just take a very attentful history. Then the recommendation is to repeat an IPT, and that will give around 60% success rate. In case of no call, we should perform a detailed ultrasound eventually combine tests and consider performing prenatal diagnosis, for example, in the form of array. Then we talked about sex discordance, which is happening around 1 in 1,000 pregnancies. And there were some interesting cases that were discussed. So I recommend you go back and check the full talk. Mostly it will be a male fetus. The test will show a male result in a female fetus. But the causes are multiple and are discussed in detail in the presentation. Very interesting talk. Then we had another interesting talk about sex chromosome anomalies, which are very common actually, or more common than we might expect. In around 0.5 to 1%, the NIPT will be positive for sex chromosome disorders. However, the positive predictive value is unfortunately not that high. So it's overall 50%. And when we specifically look at Turner syndrome, it's only 25%. So yeah, that's something that we still need to keep in mind. So when we have a Turner syndrome with a normal first trimester scan, the recommendation is to not perform CVS because it contains placental cells and it might show us again the same result. And if necessary, you can perform an amniocentesis later when the number of the percentage of fetal loss is also lower. Then we had a very interesting talk about exome sequencing. Well, it's very promising what we can do with exome sequencing, and it has the highest diagnostic yield in fetuses with multiple ultrasound abnormalities. However, it is still very difficult to report on some results, which might still, well, like for example, the variances of unknown significance that are still very difficult to interpret. The diagnostic lead in the study described was around 34%, but the population was high risk, so it might be explaining the high percentage. So the recommendation is to always relate the phenotype to the result and perform ultrasound, even in the form of 3D, MRI, and history. And finally, we discussed, Dr. Plott discusses some very interesting cases, which I recommend again you go back and see. But there's some discordances sometimes between the ultrasound findings and NIPT. All patients should be offered aneuploidy testing and ultrasound and prenatal diagnosis if needed. And it's very important to counsel parents and share expertise with colleagues. Then we proceed with the OC sessions. It was very interesting, a lot of new insights. So first of all, even very early in the pregnancy, around 7 to 10 weeks, we can look at the fetus when there's a medical indication for it, and we can find already some abnormalities. So it's very important to realize that already at that early stage. We also had some presentations about what women want for, that's very important. We have to also consider that. So around 95% of parents with a previous scan positive result following an anomaly screening or with an affected child would still undergo a 13-week scan when asked to do so in the following pregnancy. Sonographers are also playing a big role in this implementation of first trimester ultrasound, and we see some learning curves for sonographer, and these are different for each organ that we look at. And also, of course, when implementing this screening, we have to take costs into account, and we've seen that the cost for each pregnancy for first trimester screening for anomaly scan will be of €73 per pregnancy additionally. When we look at the specific anomalies, we have seen that the ratio between the head circumference and the abdominal circumference below the 10th centile is a very valuable tool in the screening for spina bifida, and it has a higher sensitivity than the examination of the spine alone. And also we looked at ductus venosus agenesis and saw that it is feasible to see in the first trimester, and that is something that we can also keep into account when performing our first trimester scan. Also about ductus venosus, the recommendation in case of an abnormal ductus venosus is to follow up with cardiac ultrasound at 11 to 22 weeks and a growth scan at 28 weeks. And finally, when looking at the face, we can check the integrity of the secondary palate by performing a posterior coronal plate of the fetal face, which is also easy and can be implemented. And megacystis is also something we deal with in the first semester. So when a longitudinal bladder diameter is below 12 millimeters, we have actually a good prognostic value. So the last session was about the management of abnormal screening test results. Katia Bilard and Francesca Grati talked about the implementation and interpretation of positive NIT results. So in particular about rats, rare autosomal trisomies, and we've seen that actually their clinical utility is not yet demonstrated. And true fetal mosaicism for rats does not mean that the individual will always be affected or even affected at all. So a positive NIPT result could be due to mosaic in the fetus, in the CVS, and therefore, as we already heard before, amniocentesis is the recommended test. Trisomy 16 is the only rat with enough evidence for pregnancy complications and fetal anatomy anomalies, but the risks are very individual and are poorly defined. And finally, positive NIPT results for monosomy X is complex to manage, and you always have to relate it to the anatomy that you see in your ultrasound. The last was a very nice talk from Professor Chitti on fetal exome sequencing, which is very promising, but it's so difficult to interpret sometimes. We should always relate the phenotype to the results and always offer parents extensive pre and postnatal counseling. There's a lot more. I invite you to go back and check all the sessions. They were really great. And I'd like to give the word back to Elisenda, who will continue talking about infections.
Hi. So we will start talking about infections. I'm Monica Cruz, and the next workshop was the infection in pregnancy, including COVID-19, the latest data. Sorry,
I had said Elisenda was the...
Don't worry, Frances. So for this workshop, you want to go ahead with the slide? For this workshop, we had a lot of presentations regarding COVID-19. So the first one was from Dr. Bob with the COVID-Preg registry, which is one of the international registries that was presented. This is the International COVID-19 in Pregnancy, which has 240 co-authors, 158 hospitals, 23 countries and 5 continents. It's coordinated in Switzerland. And they will have an interim analysis of 1,000 patients at the end of July, and it's ongoing. The next registry was presented by Dr. Lees, Dr. Christoph Lees from the UK. It's the Pan-COVID, which is also an international registry now, but it started as the UK registry, incorporating first Hong Kong, China, Brazil, and now incorporating more centers that will start to join. And it's a registry that is not only for COVID-19 confirmed cases, but suspected cases. So you have positive and negative cases that are included in this registry. The next presentation was by Dr. Thornton. He did a very nice summary about what the data on COVID really shows. And he started by saying that unlike SARS and MERS, compared to SARS and MERS, we actually have better outcomes in pregnancy. However, we need these registries because there is no very good data at the international level. Maternal mortality seems similar in women that are pregnant and not pregnant when you compare, and that neonatal infection seems to be quite uncommon, and that most registries or most meta-analyses are showing that changes in breastfeeding, cesarean section, for example, or separation at birth really have no changes or no incidence in the management of these pregnancies. So these were the three presentations for COVID-19, and then we have presentations on other infections, which are obviously very important. And Dr. Yvil presented beyond COVID, what is new in the world of congenital infection, and particularly new things about cytomegalovirus infection, which I think he also mentioned in the last session, that most CMV infections are not primary infections. However, the primary infection is the one that is mostly associated with sequelae at 2 years of age. That infection prior to 11 weeks, and he showed very nice data on this, is the one that is associated to neurosensory impairment. So it's really, really important for us to start considering screening for cytomegalovirus, even preconceptionally. that certain risk factors are associated with up to 9%. I did not elaborate in this. I think Ellie will elaborate a little bit more, but being a white female around 35 years of age with another child, there are certain risk factors that fit a perfect profile for having up to 9% risk of CMV infection during pregnancy. And he showed a very nice trial from Lancet this year where valacyclovir in first trimester or periconceptionally decreases the transmission for CMV. So this is very important, and this is something that was very discussed and was considered. And the last talk was by Dr. Gustavo Mallinger, where he spoke about fetal evaluation in congenital infection. And he basically made these 3 points because he showed a lot of examples, but he made this emphasis on these 3 points: that most fetuses with congenital infections will not have ultrasound or MRI findings, that transabdominal ultrasound is limited. It will miss the majority of cases with symptomatic infections. So you have to consider transvaginal ultrasound and neurosonography to evaluate correctly the brain. And having an affected fetus with a normal second trimester ultrasound does not exclude fetal involvement. So this is very important, and you need to do follow-up, and you need to do a series of exams to be able to see how these children evolve. And finally, in the same session, Dr. Mallinger and Dr. Herrera presented various cases on CMV and toxoplasmosis. And we went to the oral communication abstracts, infection in pregnancy, including COVID-19, which I co-chaired with Laura Riley Ipsville. And first of all, we had a very nice talk, introductory talk from Dr. Christoph Lees on avoiding COVID-19 in your practice. So this was mostly important, and you can read the guidelines, but it's more important to watch the video about what you can and cannot do, and what you should do, and the way you should use protection when scanning a patient. And then for the oral abstracts, Dr. Daniel Di Masio presented a multinational study. He presented 2 abstracts, the first on perinatal results and the second on maternal results, regarding a multinational study of 388 patients in 73 centers, 22 countries that spanned over Europe, USA, South America, Asia, and Australia. And his numbers showed that COVID-19 was associated with a higher risk of neonatal mortality and preterm birth, although the preterm birth was mostly iatrogenic. They did a cesarean section because most of their data was from the beginning of the pandemic, not recent. There was a low rate of maternal mortality, but 11.1 admission to the ICU for the mother, and that their risk of vertical transmission seemed negligible. To him, it was 0.4%. And for the other abstracts, we have a very interesting abstract from Dr. Adams from Canada, where he showed the example of a telerobotic ultrasound system, where they tried to evaluate first and second trimester ultrasound 600 kilometers away from the patient. And they showed that it's limited still, but it's enough for fetal viability and presentation during the pandemic, when you need to evaluate whether a baby is breech or not. The final 2 abstracts, one came from Brazil and the other last one came from Mexico, were from Dr. Sueli de Melo and from Dr. Martinez Portilla. The first from Brazil were 491 pregnant or postpartum women with COVID-19, and they reported a maternal mortality rate of 13%, which they are attributing to comorbidities, primarily obesity. And the cohort from Mexico, which was an epidemiological cohort from 5,289 pregnant women, 89 maternal deaths, and 1.6 approximately mortality. And they also did a regression analysis association with age comorbidities such as diabetes, hypertension, or obesity. So we had presentations and a lot of discussion on the disparity of the results depending on the way and the place the pandemic has been handled. So Ellie will give you the final masterclass on congenital infections.
So we finished the day the day of infections with very nice presentations. The first was by Ipsville, and I really also recommend and watching because it was very nice. He went more in depth with this new idea or new data about the cytomegalovirus. giving a very, very strong evidence about the importance of the first trimester, and suggesting that you have to do serological screening if your country has a seroprevalence above 50%, because if you detect that you have a primary infection of cytomegalovirus, valacyclovir is going to reduce the vertical transmission from 10 to 30%, from 30% to 10%. So this is a good take-home message. And the second one is that you can do amniocentesis before 18 weeks if you want. You don't have to wait until 20 weeks, but always after 8 weeks after the primary infection. So this is also a very new information, and also confirm that prognosis based in ultrasound and MRI can be very reliable. If both negatives, the risk of severe abnormalities is very low. And we also have the presentation with Asma Khalil. She reviewed the Isuog guidelines congenital infection. So it was a very nice overview about that. So I recommend you to see this presentation, because she really goes straight forward to the most important data about these infections. And I think that we are almost doing with the time. So I think that if we have to know if we have questions from the.
I think you have 3 minutes or something like that, but I don't know if we have questions or not.
If we don't have questions, maybe we can summarize in just one sentence, maybe. What about you, Monica? For heart.
From heart, I think that you have a lot of abstracts from 3-vessel view and things like that, but from heart, I would seriously recommend for people who like scanning heart, the presentation on the types of ductus arteriosus. It's beautiful. The types of ductus arteriosus were very, very nice, and they are really useful for someone who does fetal echocardiography. And technology is also the future. I would say that for heart, the AI that they showed for 4-chamber view, and also for infections, the telematic screening, this pandemic is changing a lot of things that we're going to do distance-wise, like this Congress.
Okay, about the fetal surgery, I would say that there is still a room to improve. It seems that fetal surgery has everything done, but not. We have a lot of things to improve, and I think that in the next years we will have more new data about that. So I also recommend to see the presentations, and if you are expert or fetal surgeon, you will enjoy very much. I don't know if Francesca, you want to summarize the first trimester in one sentence?
So I think we've had some great sessions, and I think the main message is that we're growing really fast, and we are moving always more and more towards the first trimester. And there are big challenges with these new genetic opportunities that we have. And I think the main point that we learned today is sometimes genetic testing can be very challenging to interpret, and we should always relate it to the ultrasound and try to really find a connection between what we see between the two worlds. And whole exome sequencing is very promising, still challenging, but I think we are doing really big steps very quickly. So it sounds very promising.
Okay. And Monica, about infections, one sentence and we finish.
I think for COVID-19, the coin is in the air. The cards have not been dealt. We have absolutely no idea for a lot of things. We assume a lot, but we really have no hard data yet, not really good data yet. For CMV, I don't know. I saw Professor Ville's presentation also, and I think everyone should see it. Yeah. And we should consider screening for CMV in everyone.
Okay, so I think that we got it. We did this great summary in less than 20 minutes. So I think that it's time to say bye to our audience. And well, thank you, Monica and Francesca, for sharing this moment. It was a pleasure.
Thank you both.
Okay.
Thank you very much for watching.
Thank you very much, and everyone enjoy the rest of the Congress, and we will see each other virtually in the next days.
Okay.